us this morning.
Yeah, thanks for having me.
So you are the editor-in-chief of the Journal of Psychedelic Psychiatry and the host of...
New Perceptions podcast.
Yep.
And you are based here in Kansas City, Missouri.
Yep.
Are you from the Kansas City area originally?
No, I'm actually from just down south, but I've been in Kansas City for over a decade. I did medical school here and then my post-medical school training also.
So tell us how you came to be the editor-in-chief of the Psychedelic Psychiatry.
Yeah, so it kind of started out as an over-lunch discussion with some of my colleagues in training, and we were talking about how there seemed to be a area of the medical literature that wasn't being addressed for psychedelics in practice of psychiatry. There's a lot of evidence from the psychopharmacology standpoint on what the mechanism is, how these drugs work. There's also a lot of case reports on when stuff goes wrong and what we see, but there hasn't been a lot in this area of what I term psychedelic psychiatry, which is the implementation and use of psychedelic and psychedelic-like substances in clinical practice. And so that's basically what the focus of our journal was. And over a couple of lunch discussions with some of my colleagues, I basically started to research and found out that, yeah, we could start a journal. It wasn't as labor-intensive as I thought it would be, especially for an online print version. And we, over the course of about 6 months, developed our first kind of overview of what it would look like, and then within about 3 months after that, published our first one in December of, I believe, 2019 at this point, or 2018, one of the two, and it was great. So.
And it's actually an online journal.
Yep.
Is there a paper copy of it produced too?
There is not a paper copy yet. You're more than welcome to print off the PDF if you really want to, but our subscribership is probably not high enough to justify spending all the money on a print one, so we've stayed predominantly online.
So what do you think the public perception of psychedelics in medicine is currently, and how has it changed since you've been involved?
I think it probably ever since Michael Pollan published his book, How to Change Your Mind, the public perception has dramatically changed. I think there was a large underground movement, mainly started by MAPS from the 1980s onward, that really did a great job of kind of holding the line for psychedelic-based substances, but I don't think it really broke through into the mainstream until Michael Pollan started doing his reporting in the New Yorker and How to Change Your Mind. The medical community is somewhat mixed. You kind of have the older practitioners who were around whenever these substances were just kind of being freely used in society, seeing a lot of abuse cases of high, LSD, MDMA, all of those things from the 70s, 80s, and they have somewhat mixed reactions to their reemergence. But I do think that the newer and younger individuals who are practicing now see the benefits, and I think I would kind of throw myself into that there are definitely risks to these substances, but there are profound benefits, and especially for conditions where we don't have great treatments in eating disorders, substance use disorders, we see a profound possibility for using these drugs to be very, very effective.
Do you think that there's any benefit to changing the terminology regarding these substances? Is it okay to call them drugs? What's the implication when you call a substance a drug? As Michael Pollan discussed, the definition of drug is really what the FDA has determined it to be.
Mm-hmm. Yeah, and so I think cannabis is probably the best example of this. And so in general, from a medical standpoint, I think of a drug as something that has a dose-response curve. So if I can provide you a substance, I can tell you how many milligrams of that substance there is, and I can tell you at what dose you're going to respond to that substance and what dose you're going to have side effects. With plant-based substances like cannabis, I don't quite know how much of the drug you're getting, and so it can vary from different strains, or in the case of mushrooms, we can estimate about how many grams you're going to get, but we don't know down to the milligram how many doses of that active ingredient you're going to get. And so I think for cannabis, the reason that I am somewhat apprehensive about the medicalization of cannabis is that we're medicalizing a plant. Now, we can talk about the legality of whether that should be allowed to be used, but I think if there is an active component that can be extracted and be placed on a dose-response curve, it should be, if it's going to be prescribed in a medical setting, because patients should be able to know exactly what they're getting, what to expect, and at what doses that range should exist in to have those positive responses. And so I think for psychedelic-based substances going forward, I think that's why psilocybin has been great, because we can actually extract it. LSD has the ability to be monitored based on milligram dosing or microgram dosing for LSD, where with mushrooms, cannabis, we kind of have this art of medicine that kind of comes in, or just art of pharmacology, where it's take a couple of these leaves or take a couple grams of these mushrooms, and I think that is not conducive to the current medical establishment in general, and just as far as we would dose things. And so that would kind of be how I would break up, those two different categories of substances.
What are you finding in the research articles that you are publishing? What is happening in the brain? What is the research telling us that these, compounds that are extracted, what are they doing?
Yeah, so Robin Carhart-Harris in London has actually done probably the most amount of research on this, and so I would encourage all of your listeners and viewers out there to go read his stuff. He's got some very, very good interviews, some with Michael Pollan as well. And what we see in the, I don't want to call it neuro literature, but probably from an fMRI standpoint, which is where we look at what your brain is doing under these states, and we see the changes in blood flow, we see the changes in brain activity. What you're seeing is that areas of the brain called the default mode network, which is kind of this baseline operating procedure that's going on at all times, your default approach to the world, how you interact with people, gets turned way down. So those aspects of the brain aren't operating at full strength or even in high doses at any strength at all. And so your brain is allowed to form new connections with different parts of the brain, and that basically allows you to adapt and change. And so probably the best way to describe this is looking at something like OCD, where in OCD you have this hyper-rigid response to the world, right? You have this intrusive thought that pops into your brain that, I have to wash my hands 40 times a day or else I'm going to get sick and die because of the germs on them. And that behavior gets ingrained through repetitive uses of that ritual that you're doing with your hand washing. And so you imagine if you do something long enough, it becomes a habit, and that habit gets ingrained, and then you're continually stuck in this form of behavior. Well, if I turn down that default mode network, and I basically said, you don't have to have this psychiatric process that's telling you to go wash your hands, you could contemplate doing other things. And if you can contemplate doing other things, that allows your brain to adapt, change, be neuroplastic as we call it. And so basically you can contemplate a different way of existing in the world, maybe without washing your hands 40 times a day and just washing it, when you go to the bathroom before you eat food. And so that's where these substances really seem to work, is helping people that have highly rigid, highly ordered thought processes and kind of turning those down, or who have highly habitual aspects to their life, such as substance use disorders, where they get stuck in this loop of using tobacco, alcohol, other drugs, and they just get stuck in those loops. We can actually kind of turn down those responses that are almost innate in patients and give them 6 to 8 hours during a trip to contemplate what life would look like when they're not using those.
Are there certain practices that you've explored outside the implementation of psychedelic medicine that could complement a regimen that's prescribed, if it is prescribed eventually, such as breath work or meditation, and what's the relation between those practices and the default mode network?
Yeah, so you can achieve non-ordinary states of consciousness through just normal, what we call holotropic breath work or meditation. There's great studies going on, I believe at Stanford, that are looking at this, which is, you can do this through meditation, you can do it through physiologic changes, just breathing faster and slower at different times. The only caveat to that is it takes much longer. So practice meditators take decades to achieve those non-ordinary states of consciousness. And so it's definitely possible, but as far as wide-scale use for medical conditions, I feel like psychedelics offer you that shortcut, and that's where the caution comes in, right? Because anytime we're taking a shortcut, there's always a risk that we're going to abuse that potential, and so we always want to be cautious and mindful that these substances shouldn't be played with in just kind of a laissez-faire, cavalier attitude. We want to use them appropriately because they can really be negatively impactful if we're not using them with the right mindset and the right respect.
And what sort of, problems are you addressing? And do you find a difference between the use of these psychedelics in, things like depression versus like substance abuse? Is there a difference in how what the research is showing between how it's treating those two problems that the society suffering from?
Yeah, I mean, I don't know that there's a huge difference in the impact that psychedelics have in those two conditions. I think in general, I try to reduce things down to the simplest common denominator. And I think, for certain conditions, depression, substance use disorders, OCD, eating disorders, all of those people tend to get stuck in, habit-forming loops of some form of behavior that's just not, it's maladaptive, it's not good for them. And that's where psychedelics can really break you free from that mold. But in other conditions, manic states of bipolar, schizophrenia, in those the brain is highly disordered, it's highly disorganized, and they may not play a huge role there as far as the macro doses of these medications at high trips, because if you add chaos to an already chaotic situation, you're just going to get more chaos, and that's not going to be helpful or constructive for anyone. And so they definitely aren't a panacea. They're not going to fix everything, but they do have the potential to work on treatment-resistant cases of depression, which is about 30% of patients with depression at the end of the day, or eating disorders like anorexia, which don't have a pharmacologic treatment really that's overly effective. We can kind of do things to mitigate against it, but they have the potential to just reshape the entire landscape for eating disorders, and then smoking cessation, alcohol use, severe drug use, all of those could potentially just be completely reshaped by the use of these substances.
As the clinical evidence continues to pile up, pointing towards the potential success of these substances treating a myriad of conditions, how much do you feel, from an insider's point of view, is the needle moving on an institutional or legislative basis?
So I think we're starting to see movement in that direction. Obviously, certain cities around the country have decriminalized psilocybin and other psychedelic-like substances in Colorado and Oregon and Washington. We're not seeing a huge push yet from the national actors like the FDA or the CDC yet. They are funding some research in coordination with major institutions like Johns Hopkins or NYU. And so we are seeing just everybody kind of dipping their toe in the water, but I haven't had a huge push yet that I've been privy to from inside the large government regulatory bodies that they're going to consider rescheduling these. I think we're going to get close once the phase 3 data comes out on psilocybin and MDMA over the next couple of years. So I'm hoping that we'll at least see a rescheduling of these substances. Right now they're Schedule 1, which means they're deemed not to have any clinical benefit. I think we can definitively say they have some clinical benefit. The degree to which they have that benefit, I think, is going to need to be further elucidated in these trials and studies. But hopefully we can reschedule it down to at least a Schedule 2, if not a Schedule 3, where common practitioners can start prescribing it, even if it's under a monitoring program that we have for other substances, like clozapine, or even esketamine is under a REMS protocol, where we basically are monitored. We have certain requirements that we have to follow, and so there's some regulatory oversight. If we could even just get it down that far, it would allow us to conduct more wide-scale studies and remove some of the burdens that we see from a regulation standpoint.
When you talk about OCD versus PTSD, they seem like quite a different set of circumstances and immediate outcome for those who are suffering. We hear about the effects that PTSD, the effects that psychedelics can have on PTSD. How is PTSD different than OCD? PTSD, in my experience, my understanding, may be related to one or a number of events that could trigger a long-term outcome, whereas something like OCD might compile over time, lots of behaviors, and something that's, I don't understand the origin of it. What's the difference between PTSD and other conditions that psychedelics would treat?
Yeah, so to compare those real quick, so OCD is kind of a hybrid of a thought disorder in that you have intrusive thoughts that you can't get out of your head that compel you to want to do certain behaviors. And if you don't do them, you generate anxiety. So you have a thought disorder primarily that can generate anxiety. PTSD is a trauma-related disorder, so usually you have some event, as you alluded to. The best example of this is like combat veterans, right? They're in war, they've experienced a horrible trauma or multiple traumas while they've been there, and then when they come back, they have usually 3 categories of symptoms of some kind. They have re-experiencing symptoms, so they have nightmares, flashbacks. They can also have intrusive thoughts. That's where some of the overlap can come in with OCD. Of the trauma, though, it's specifically related to that. It doesn't usually generalize outside of it. They also tend to have mood symptoms, so they tend not to feel positive emotion as well as other people, or they feel emotionally numb or blunted a lot of the time, and they engage in avoidant behavior because of that. So if they find a situation that's going to cause them to have flashbacks or nightmares, they avoid that, and so they get more isolated and restricted, and it can look a lot like depression in that sense. And they also have the third category of symptoms, which are these hypervigilant or hyperarousal symptoms, where they get irritable or aggressive or feel very uncomfortable, usually in crowded situations or around triggers of their trauma. And that usually causes them to look more like anxiety symptoms. So PTSD is kind of a hybrid of a lot of different disorders, but they're all unified by this one traumatic event or multiple traumatic events that are there. And the difference from psychedelic substances being used for OCD and being used for PTSD is that in PTSD, what's been effective is actually MDMA, which is more of a psychedelic-like substance. It's kind of similar to ketamine in its classification. It's not a dissociative per se. It's got some stimulant-like qualities, but it seems to be more of an empathogen or entactogen in that it helps people accept what happened and learn to move forward with it and feel more connected. And so it can actually increase some positive feelings of emotion in them. The other place it's been studied, MDMA, is in autism, where they also have problems making connectivity and social connections. And so there it can be helpful in generating empathy and just letting them understand what other people are seeing and then kind of internalize that a little bit and see how they're behaving. Where psilocybin seems to really help more with kind of turning down those default mode network and that default processing. Empathogens like MDMA tend to kind of open you up more to positive emotion, positive experiences, and whatnot. And so similar in their sense that they're altering your perception of reality in a sense, but different in their way they're acting on the brain and brain activity.
Wow, there's so much research, and I thank you for breaking down the different disorders that each of the psychedelics can best help. So the research that you accept into your journal, is there a specific focus? Do you focus on, the disorders such as PTSD or OCD or any certain psychedelics? How are you, sorry.
Choosing what to focus on.
Sorry.
Yeah, of
vetting.
all the
How are you
options.
vetting? And is the volume? I know you said the volume is low, but how are you marketing that this journal exists, and the information that you're getting, and how do you vet that?
Yeah. So our publications kind of go into three major groups. So we have original research, which is patients that are individuals that are actually conducting real-world research with patients. So they're doing long-term studies, they're analyzing their results, or they're doing retrospective studies where they're looking back at patient populations. So original publication. Then we have like viewpoint articles, which is usually written by clinicians who are in practice that, whether that's with ketamine, we've had some publications from multiple anesthesias, specialty individuals who have gone out there, and anesthesiologists as well, who have been out there using ketamine in practice and what their experience has been like and some of the pitfalls that you should want to avoid and how to use this more effectively. And so those are usually viewpoint articles. And then we have case reports of patients that have responded positively or negatively to these psychedelic substances and why it is they think they've had a positive response or not. And so those are our three major groups. We have a couple other ones like protocol-driven research papers where we actually lay out what the possibility is whenever these substances are approved. How would we use that in practice? Because psychedelic-assisted psychotherapy is a little bit different than just giving somebody psilocybin. We actually want to do associated psychotherapy both before and after they get the substance. And so there's a little bit of logistics that are involved with that, like how do you structure your clinic practice? How do you set up a time and space for somebody to be there for 6 hours or 8 hours, depending on the substance? There's a time commitment. What is the reimbursement going to look like? Cost, all of that. And so that's kind of how we group all of our articles. As far as getting out there, we have a Twitter profile, Facebook profile, pretty much every social media profile. We have a large subscriber base. We've made some contact through different medical meetings that we go to or conferences. And so we've got a pretty large subscriber base that just is available, and we send out emails and requests all the time. And so I encourage any of the viewers or listeners out there that have an article, if you're in the medical field, or you have a viewpoint article that you'd like to write, or even original research, which is even less common. But if you want to publish it, just let us know. We usually publish, like I said, quarterly, and so most of the time we get requests. Usually we get them published about either the upcoming issue or the one following that. So we work pretty good. We're a pretty small team, but we have a whole editorial board that reviews everything, vets it, reads through the citations, makes corrections and edits, and so we have a pretty good establishment. And being in the medical field, I've done a fair amount of that through other aspects of reading and reviewing literature, and so we're just kind of well placed to do that.
And what kind of research have you done personally?
So personally, I don't do a lot of clinical research. In my private practice, we're trying to scale that up right now and get into some of these phase 3 clinical trials. And a lot of that has just been put on hold because of COVID. There were a lot of these regulations that, for ketamine especially, supply chain issues, and then as ketamine was an aerosol generating procedure, and then psilocybin, a lot of those being in contact with the same person for 8 hours in the same room, really got put on hold. And so unfortunately over the last year or so, we just haven't been able to scale up anything. But we're definitely open to it, and we're engaged in talks right now to make that a possibility.
And you're also a clinical instructor. So in the field of medical education, how, in psychiatry specifically, how is this topic approached as far as early on in your medical training and then later on in practice?
Yeah, so in medical education, I think they do an excellent job of exposing us to upcoming therapies, usually in the form of like formal presentations at what we call grand rounds, which is where we all get together and listen to these topics. And we had one recently that went over different aspects of it. And then from my clinical practice, we also try to get trainees involved in treatment-resistant modalities. And so there's a field that's blossoming right now called interventional psychiatry, which is different methods and modalities that we use to treat treatment-resistant disorders. Primarily that's been in depression, because that's been one of the stickiest areas to actually treat. And so you'll hear people talk about, ECT, which is electroconvulsive therapy. It's got some negative connotations, but it's actually probably our best. And then there are other modalities like TMS, vagal nerve stimulation. Ketamine kind of falls into this group right now. And then this is where psychedelics, I think, will make their major breakthrough, at least the classical ones, psilocybin and LSD. That's where the main studies are being done right now, is in treatment-resistant depression. And then MDMA would kind of be lumped in that as well, but that'll be more for like treatment-resistant PTSD. And so we are aware of that. We try to make all of our trainees aware of it, and then hopefully through rescheduling of these substances and maybe even clinical trials, we can actually get trainees involved in using these medications while in training, so they feel comfortable to go do it once they get out in practice.
Do all of your journal publications, are all of the people medical doctors? Are some of them counselors, or what is the range of contribution?
We have a wide variety, physicians, naturopaths, licensed clinical social workers. We've had lawyers publish in the journal about the legal implications of it. And so, it's just kind of a wide variety. It touches a lot of different spheres. Again, I think because it's so taboo, it draws in a select audience, and that select audience is a very diverse group of individuals as far as their credentialing goes. And so we've got a wide array of thoughts and opinions on things. I have, even within the field of medicine, I have ED doctors, I have anesthesiologists, psychiatrists, medical doctors, toxicologists, and so there have been all kinds of different individuals who have been peripherally involved. I've even had Nick Gillespie from Reason Magazine on the podcast, and he's not in the medical field at all. He's just a psychedelic enthusiast, and so it's had numerous individuals that have kind of been from across the spectrum.
Speaking to the taboo nature of psychedelics, what do you think will have the most effect on changing public perception? You alluded earlier to Michael Pollan's work as having a great effect, but do you think that public perception is going to change public policy, or do you think that public policy is going to change public perception?
I think I would have said probably 3 years ago that public perception would change public policy. I think now we're probably going to see more of a top-down medicalization, get people comfortable with the idea of using these substances, especially for those that lived through the 60s and lived through the war on drugs and the Nixon administration's change of how we view these substances. Timothy Leary's attitudes and behaviors during that time certainly didn't help anything. And so I think we're going to see more of a top-down approach to that. I don't know if that's the right approach, but I definitely think it's the one that's most feasible, and as a clinician, it's the one I feel the most comfortable about, because I think it allows us to pay these substances the respect they're earned and not throw them into society again where they could be abused or misused, and that would potentially push them back underground for 30 more years. And I just think from a potential treatment standpoint, I would hate to see that happen. And so if I'm betting this will be a rescheduling by the federal government, loosening of some regulations with still a lot of structures in place to prevent it from getting widespread use. I don't think we're going to see massive decriminalization on a national scale of any of these substances. I think it will definitely be a medicalization model, and hopefully over time, 15, 20 years, you'll see the old individuals who were around in the 60s probably will pass on, and some of that apprehension will dissolve, but also through appropriate use and hopefully success stories, we can gain traction as well, and get people to feel more comfortable and less apprehensive about the substances.
Yesterday was Indigenous Peoples Awareness Day, and where do you think the story of Indigenous people's use of plant medicine is being told in contemporary clinical research and modern psychiatry?
Yeah, again, Michael Pollan did great work on this, detailing the entire history of all of these. I think the shamanic tradition in general is best highlighted by ayahuasca, which is the only legal psychedelic that you can do, provided you're part of the specific church that administers it. And so I think that's probably the area that it's used. I know some psychologists and clinicians who are doing underground psychotherapy are utilizing shamanic rituals and mechanisms during their trips and follow-up psychotherapy sessions, for lack of a better term, integration sessions. And so I think it's getting its due respect there. I do think that there may be a swing towards over-medicalization of this. We definitely know that putting a patient in a hospital room with alarms and bright white lights and all of that is not going to be conducive to a good trip. I don't know that we need to swing so far the other way that we take them all the way to the Amazonian rainforest either, though, to have a productive trip. So I think there's probably, as most things, there's the ability to conserve the things that work within the shamanic tradition, but also to apply, some of the progress that's been made in medical science. And so hopefully we can find a hybrid balance there. I just don't know what that'll look like quite yet. But I think failure to pay respect to those specific entities that have been using these substances for thousands of years, if not tens of thousands of years in certain cases, would be a mistake. And again, we would definitely want to take what works from them, and we want to incorporate that into our practice, because it definitely benefits the patients whenever we pay respect to them and the substances that they're being used in.
Speaking of minority populations, with your idea that it might be a top-down approach, how do you see that affecting, the disparities in access to treatment if it's coming from the top down? Because I feel like, the war on drugs and things like that, there was a component to it, a social component to it that sort of affected a lot of minority populations, and those that really need access to this type of care, that are suffering from a lot of these disorders. How do you see that playing out if it does come from the top down?
Yeah, I think that the implementation of these types of substances into clinical practice are going to be what's extremely challenging. I expect that, given the nature of the duration of these substances, 6 to 8 hours, the amount of staffing that will be necessary, that these are going to be initially pretty expensive procedures if they're not covered by insurance. And so I think that is definitely going to be cost prohibitive. I liken it to the big screen TV craze of the 1980s, where a big screen TV cost $10,000 in the 1980s, but now we can all go to Best Buy and get a big screen TV for $300 or $400. And so unfortunately, I do think that we're going to see a disparity in the individuals that can get this substance initially or get these treatments. I think you'll see a lot of fancy individuals going to get private retreats, and they'll be setting up all of those. My hope, though, is, and if it's anything like the rest of the medical establishment, LASIK surgery is probably the best example of this. It was an extremely expensive surgery in the early 2000s, late 1990s, and now it's relatively affordable by medical terms. It's one of the things that's actually gone down in price over the last 20 years, and so I'm hopeful that we'll follow that same model, and I think that insurances will ultimately end up paying for it, so hopefully that won't be a huge issue. And the reason I think insurance will be more inclined to pay for it is, would you rather pay for a drug that you can take every day and risk not having a full remission, or would you rather pay for 1 or 2 psychotherapy guided or psychedelic-associated psychotherapy sessions, where you're administering a substance and then about 5 to 6 psychotherapy sessions on either side of that as a one-time potential cost or maybe a once-a-year cost. And so I think you can probably do a cost-benefit analysis that would at least average out to, hey, I'm not having to pay for medication trials, hospitalizations, and other negative health consequences from depression, anxiety. All of those have medical problems as far as heart disease, diabetes, obesity, all of those add up. And so I think in the long term, the cost benefit will be there. I think initially, we're probably going to see some isolation of this to the people that can afford to pay for it. And unfortunately, that's just how new medical technologies work in general. New cancer agents, new pills, all of those start out at a very expensive price, and somebody has to pay that price. But eventually, if enough people start using it, adopting it, it becomes wide scale. And so I hope that'll be quicker than slower, but I just don't know at this time. But I do think that's how it's going to probably play out.
Speaking of those types of medications that are taken on a daily basis, potentially with some long-term side effects, that sounds like pharma companies to me, right? And there's a financial component to that, right? That we live in a capitalistic society, and so how do you think pharma is gonna play like the capitalistic, money-hungry type thought process that we all sort of attached to pharmaceutical companies? How do you think that's going to play into this, and what is that going to look like with regard to what you said, sort of a different approach to this treatment?
Yeah, I mean, I think some pharmaceutical companies will probably undertake synthetic processing of psilocybin and actually making it available. I'm sure some other ones won't, because they'll want us to use their other drugs, and I don't want to ascribe motive to them. I'm sure they all have their own board meetings and profit decisions where they go through and they're like, we would prefer everybody be on drug X for depression instead of this one. And so, but it'll create a market incentive. I think there'll be a company out there that if they're not producing other medications in that vein, why not take a shot on psilocybin? I mean, the profit motive, I think, will be there to generate that, because you're going to have, depression in general around the world is like 100 million people have severe depression. I mean, it's like the #1 driver of severe morbidity as far as lost life years and everything else. And so I think that there'll be a huge market for it. And so I think some pharma companies will want us to use their drugs, but others will probably see an incentive to get in there and use it. The only question that'll be there is, how much are we going to have to pay for it initially? These things, I don't know if they'll be on patent or not. That will definitely affect how long, how high the price could go, of course, because whether a drug is on patent or not really affects the pricing of it. And so if they have a novel delivery device, that may change things. Like S-ketamine is different than IV ketamine, which is generic. And so I think they may try to get in there and come up with different ways to utilize it. But hopefully this will be common practice, and it will be in the common domain as far as psilocybin and LSD, because they've been around so long, that hopefully they'll just have companies that can synthesize them and we can use them at a relatively affordable rate.
Piggybacking off of Autumn's question, we hear about how a 5-hour session of psilocybin guided therapy could be equivalent to potentially 5 years of appointments and effort leading up to that. Monetarily speaking, where's the incentive for institutions, industry, pharmaceutical companies to solve and cure conditions as opposed to treat and set a prolonged schedule of substance intake to mitigate symptoms over time? Because I think we would like to see these conditions and the suffering from them end, but is it to the financial advantage of these companies that are working on these compounds, which is supposed to have greater effect, more whole effect? I'm always conflicted when I think about a future where companies are incentivized to end what they're paid to treat.
Yeah, so I think the caveat there is we're not going to end all mental illness, right? So I hope for the day that I could basically treat patients that have schizophrenia or treat patients that have bipolar disorder, which are not curable conditions. They are chronic, long-term conditions. We can mitigate the symptoms, we can manage the breakthrough symptoms that come through and the decompensations, but there is no cure for those. But unfortunately, my clinic is not filled up with a lot of those patients. Unfortunately, we spend more time treating depression, anxiety, those symptoms that manifest from physical illness, whether that's cancer or heart disease or whatever else. And we are drastically underserved as far as our ability to provide care for that across the nation. We have more mental health providers, psychiatrists, psychologists than anywhere else in the world, and we're still far from being able to treat all of the people that have illness. So I don't think that we're going to see a fundamental reshaping of the landscape to that degree to where people have to worry about squeezing out of their profit motive. I think people will always have some depression, always have some anxiety. The question is, does it rise to the level of being so severe that you need this substance? And I think there will be somewhat of a gating process done by the physician saying, you know, is severe depression where we cut this off, or do I use it for mild depression? Is the patient appropriate to use it? All right, should we be using it in teenagers, or should we try to manage this with just therapy? Is it appropriate to use this in a family member that has schizophrenia or bipolar? So there will be patients that we won't be able to use these substances in, at least in the near term, and then potentially even longer than that. So I think that while those reservations are fair to lay out there, I think that the nuances of clinical practice should mitigate against them using that as a rationale for not wanting to produce those substances.
Well, Dr. Kjorvestad, we really appreciate your time this morning.
Yeah.
Thank you.
Thank you guys for having me.
Yeah, you'll have to come back by and we'll have this conversation again. There's always something to add to it, right?
Absolutely.
And it's good to know that your journal the subscription is free.
Yeah.
Anyone can subscribe and read up on all the research and the thought-provoking articles that you publish. So thank you for the work that you're doing.
Well, I appreciate it, and just let me know if I can do anything else for you guys.
And the podcast can be found?
Pretty much anywhere you can subscribe to podcasts. We're available on all major platforms. So it's New Perceptions.
Thank you very much.
Yeah, thank you.